Hello everyone. Thank you for joining us for day 2 of the Health Data Research Network Canada Pragmatic Trials Training Program Conference. I will be the moderator for today. My name is Sabrina Hoa. I'm a rheumatologist at the University of Montreal, and I do research on scleroderma. I would like to start today with a land acknowledgement. We acknowledge that the Pragmatic Trials Training Programs Coordinating Team's offices located in London, Ontario, are on the traditional territories of the Anishinaabe, Haudenosaunee, Unapiwak, and Atawandaron. This land continues to be home to diverse Indigenous peoples, First Nations, Métis, and Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. We also recognize that our work is carried out on the traditional territories of First Nation, Inuit, and Métis people from coast to coast. We are thankful that we are able to work and collaborate on these lands. This morning's conference presentation will run from 11:10 to 12:10 Eastern Time, a quick lunch break from 12:10 to 12:55, followed by our afternoon presentation from 1 to 2 p.m. Agendas, speaker bios, and session links can all be found on the left-hand menu. And to help you navigate today's event smoothly, here are a few housekeeping details. So a reminder that the conference will be recorded and a copy will be sent to attendees. Each session will begin with a presentation by one of our trial leaders, followed by a panel discussion and concluded with audience question and answers. If you have housekeeping questions throughout the day, please add them to the session Zoom chat. You can also privately message another attendee by navigating to the networking tab on the left-hand menu. Lobby chat will not be monitored, so please use the session Zoom chat. During the audience question and answers, please feel free to raise your hand, hop off mute, or add your question to the chat. Any questions we don't get to during the Q&A will be sent to the presenter. And we also welcome your feedback on the presenter's protocol. Any feedback added to the chat will be passed along to the presenter or can be emailed to us at pragmatic.training@uwo.ca. All right, so let's get started. So it is my pleasure to introduce our first presenter, Dr. Pavel Rushanov, who is an expert in nephrology. Today, he will be presenting his trial, Dialysis with Expanded Solute Removal. Following the presentation, we'll have a panel discussion featuring Terry Chanda, Amy Fryer, and Corey Goldstein. So please join me in welcoming Pavel.
Wonderful. Huge thanks for the opportunity to present this important trial that we're about to get off the ground. It's called DIALEX, stands for Dialysis with Expanded Solute Removal. It's a very large, simple study to evaluate the major health effects of two forms of hemodialysis that are provided by two different types of dialysis filters. I don't have any disclosures in terms of personal payments to disclose. I don't accept any industry payments. I am an investigator on numerous investigator-initiated projects that are supported by industry partly, but those folks never have any say over the interpretation of the results or the publication of the results. And I'm a site investigator on several industry studies that recruit at our centers, but all of my compensation for those goes directly to our research staff. So I'm going to talk to you about dialysis. Many of you may not be familiar. Dialysis is a form of life support. It's a form of outpatient life support for the millions of people that live with kidney failure. Kidney failure can happen to anybody. There's so many ways that one can have their kidneys fail. And without dialysis, or the much less common, unfortunately, kidney transplantation, kidney failure is fatal. Even with dialysis, 60% of patients die within 5 years of starting dialysis. So it's by no means a complete therapy. Unfortunately, we don't know how to prevent these deaths, and so we need to study that. Dialysis systems, the way that we provide dialysis, are fairly complicated, and a conservative estimate is that they include at least 30 different components or parameters that we can change in these systems. There's fairly little evidence to support the selection of these choices, and they're prone to noise, bias, and marketing because there is so little robust evidence. Often these things are selected administratively. So this is everything from the dialysis machines to the filters to the sorts of solutions that we use. And volume-based pricing, so contracts that help our institutions save money, actually end up having a really big role in the decisions as to what kind of equipment we use. So this study is about dialyzers or dialysis filters, and I'll use the term dialyzer from here on, but this is really a plastic tube that sits on the dialysis machine, the hemodialysis machine, that cleans the blood. It removes salt, water, and toxins. And these toxins come in various shapes and sizes. And some filters are better at removing a larger repertoire of toxins than other filters. We don't know the full implications of removing more of these molecules. When you get to some of the larger molecules, what could be characterized as a toxin could also have a role that's important in the body. And so we don't know what the benefit would be of removing it. It's possible that they would not be beneficial at all. And so we need to actually get real data on how different kinds of dialysis filters affect major health outcomes. But these dialyzers are really purchased by hospitals, by institutions in these volume-based pricing contracts. And like many things in healthcare, there's sort of an illusion of clinical autonomy in terms of our choices of equipment or medications that we use in the hospital. The availability of all sorts of drugs and devices differs from one hospital to another. As little as, going down the street to a different institution, you might have different antibiotics to treat the same infections, different blood thinners to prevent the same blood clots, medications to treat anemia in dialysis patients are different from one institution to another. Vascular catheters, different choices may be important clinically, but they have different costs. And so different institutions use different ones, procedural equipment, and in our case, also dialyzers. So who gets to choose? It's not really patients. They never hear about the different options. It's not really care providers. Many of us get used to working in the health system that we work in, and we're used to using whatever's available. It's usually these are administrative decisions, sometimes with input from healthcare providers, but in the absence of strong evidence, the kinds of things that drive the decisions are how can we save money? And sometimes it's a matter of how aggressively the companies market. So large studies are really necessary to inform the selection of these different either equipment or medications of which we could choose one way or another in order to provide us with true clinical autonomy. So we could be actually armed with real data to go and say, hey, we want product X because it has the following benefits. Key barriers to actually acquiring the necessary data from large randomized control trials in dialysis is that, one, the treatment effects of anything that we do, we expect to be small to moderate, and they're exerted over a very long period of time. So we need to enroll many patients and follow them for a long time. So immediately you start to get into studies that are very expensive. The population's overburdened, and it's not a huge population. And so they have many medical visits. They come to the dialysis unit 3 times per week. People don't really want to do any additional visits, fill out additional forms, do additional tests. Dialysis is delivered largely in community hospitals. It is also delivered, of course, in our academic hospitals, but much of dialysis is delivered in academic, or rather in community hospitals without access to research infrastructure. And so a sort of inequity is created where patients who dialyze near their home do not have access to research studies the same way that patients who are in a large urban center close to an academic hospital. And then, of course, purchasing contracts can create constraints where we're not actually able to study different alternatives because our institutions are locked in with one of them. And unfortunately, there's not much commercial interest in research on these things. So our objective for this study is to evaluate the major health effects of 2 different classes of dialyzers. It's an individual randomized trial, individual patient randomized trial, where we perform individual randomization of 4,800 patients. And they will be randomized either 1-to-1 to receive what we call expanded intermittent hemodialysis using one type of dialyzer, the Elycio HX dialyzer from a company called Nipro. There's other dialyzers like it, but this company is helping us by actually providing us some discounts on these dialyzers. And then comparing that to conventional intermittent hemodialysis using any of the usual dialyzers that a program might be using. And everything else is per usual care. Now, that's what we do in centers where the contracts are such that it's favorable for us to be able to do that. But there are places where the contracts prevent us from randomizing many patients to the expanded hemodialysis arm. And so in those centers, if we're restricted by a dialyzer contract, we use 1-to-3 randomization, where 3 patients are randomized to conventional hemodialysis for every 1 patient.
Well, I think we need to have you exit the meeting and then come back. For some reason, there's the audio cut out.
Is this better?
There we go. I can hear you now.
Okay.
I'm sorry about
Where did the audio cut out?
about 30 seconds ago. It was before you went, we muted you just to try to.
Okay. Yep. Well, thanks for doing that. So I'll back up. So the eligibility criteria are the following. It's patients who have been on dialysis for 3 months or longer, patients who are receiving intermittent in-center hemodialysis at least 3 times per week, and that's most people on hemodialysis, and patients who are 60 years of age or older, or who are 45 to 59 with diabetes. And these are the people that are really at higher risk of death. And that's why we've chosen them to really enrich the trial for people who are at risk of death, because that is going to be our primary outcome, what we're trying to reduce. Then people who have a valid health insurance card number so that we can follow their outcomes using administrative databases. We will exclude patients that the nephrologist doesn't think are appropriate for the trial for a number of reasons that we list, including either very poor adherence to treatment, folks who don't come often enough, a clinical preference, so if the nephrologist doesn't feel that it's appropriate to be randomized, then we won't do that, or different kinds of dialysis that are not compatible with these kinds of dialyzers, and of course, patients who decline participation. The endpoints are simple and they're ascertained in a simple manner. The primary endpoint captured through Statistics Canada is time to death from any cause. So that's a national database, the National Mortality Database. Anywhere in Canada, we can capture that. Key secondary endpoint is cardiovascular or infection-related hospitalizations, and that includes recurrent events. This population is hospitalized very frequently, 1.1 to 1.3 hospitalizations per patient per year on average. And a number of other secondary outcomes, including different subtypes of hospitalization and also time to receipt of a functioning kidney transplant. Then there are some tertiary outcomes that are captured in Ontario using the Ontario Laboratory Information System, chart review in select centers that collect routinely patient symptoms so that we can understand whether these dialyzers make patients feel better, and then Ministry of Health databases in Ontario for costs. And this is a typical sort of scale, something called the ESAS renal assessment system that many centers use, routinely administer their patients to have them score what their symptoms have been like on dialysis. So we would simply be abstracting that from patient charts in those participating centers. The enrollment and consent procedure is actually that of opt-out consent. So the healthcare provider confirms eligibility. A notification to eligible patients or their substitute decision makers is given in the form of a handout, and I'll show you what that looks like. The nurse champion or research coordinator logs the notification that it's happened. They're given 2 weeks to opt out. Patients can do that in a number of ways, whatever works at that center, either leave a message on the phone, send an email, sign the handout itself, and gets dropped off in a Dropbox, give it to the nurse that's their dialysis nurse that day, or tell anyone in their care team. Then the local providers enter the health card number into a randomization portal. There it remains encrypted and inaccessible to the central study team. They click randomize, they see what the allocated dialyzer is, and they prescribe that allocated dialyzer. And then from then on, the only post-randomization activity at bare minimum in centers is every 6 months to confirm adherence to the dialyzer. It's a simple web-based enrollment form. It just has the eligibility criteria, the health card number, and a check that to make sure that people have had at least 14 days from the time of notification before they're randomized. This is the two-sided handout. It clearly identifies at the top you will be enrolled in the study unless you explicitly decline participation. Explains what the study is about, even points to a website if people want to find out more, and then gives them an opportunity to print their name and decline on it on that date. So is alteration of consent acceptable? So we worked on this for a long time. We've really been working on this trial for about 2 years now. And our steering committee also includes patients who, it was interesting, we formed a committee of patient partners with whom we explored both the context of dialysis as a setting where mortality rates are very high and we have a lot of uncertainty. We explored the barriers to actually getting studies done in dialysis. And we explained to them what dialyzers are about, how they're purchased, and so on. And with them, we went through the various options that we have for consent. And our patient partners felt very comfortable with the idea that we use an opt-out consent approach as described. But this has lots of precedent. So internationally, there are at least 13 national or regional guidelines and 1 international guideline. These apply to 39 countries that provide some criteria, basic criteria for what would justify alterations of consent like this. So the study has to be minimal risk. It doesn't mean in a minimal risk population or even of a minimal risk intervention, but rather that any of the procedures that are study procedures actually bring little risk beyond what would be brought in usual care. And we think this study meets that. If people were to go to a different dialysis unit, they might be getting a different kind of dialyzer. It's unlikely to adversely affect welfare. And certainly, we don't think that anything about this study is likely to adversely affect patient welfare. We do agree that it is otherwise impossible, or more importantly, impracticable. Everything is possible with enough money, but a study like this, of this size, able to answer this question definitively, would cost easily close to $50 to $100 million to do the way pharmaceutical companies do studies. So lowering those barriers so that we can make it something fundable by public money is tremendously important. And moreover, we would really not be able to do the study at all in community centers if we made the consent procedure more involved. We did consider what it would be like to have practitioners explain the study to patients and actively consent them into the study as opposed to the opt-out consent process. It was very clear that that would not work at any of the sites. The vast majority of community sites do not have any research support. They're very busy dialysis units. The investigators, the care providers there are not trained to be investigators, and they also provide direct patient care. And so they felt that it would really not be appropriate for them to be doing this. They'd be happy to answer questions for the relatively small number of patients that we anticipate to have questions or to want to opt out of the study. But that's very different than prospectively consenting every person. And of course, plan to provide a debriefing that may also offer the participants the possibility of refusing consent, and that is what we're doing. So the organization and oversight of the study, there's a lot of oversight that goes into these things. This is going to be a landmark study that when we are done in 6 years from now is going to be scrutinized. And so we certainly want to make sure that everything is above board. Many people are involved. There are steering committees, project office operations committee. There's a special data monitoring and safety committee. There's a blinded statistician, an unblinded statistician, and a number of other committees that oversee things like sub-study and publications and regional operations. I'll tell you about the Data Safety and Monitoring Committee in the study. It's an independent, unblinded committee. There's an experienced statistician, a trial leader, and a clinical expert. And these are really among some of the most experienced people in clinical trials. At any time, they can recommend changes to the study, including stopping or extending the study. They can also request additional analyses. Twice yearly, they review enrollment and opt-out rates, baseline comparisons of demographics and clinical history, the rates of adherence to the allocated therapy and the reasons for non-adherence, including mortality. So they do get mortality rates as well. And they do see these data by study group, whereas we, the investigators, do not see these data by study group. And they also will see the results of a single pre-specified interim analysis that we've pre-specified for 50% person time. And then if they want to, they can call for additional interim analyses at any time. This is the summary of the design. Simple eligibility criteria, 1 of 2 allocation ratios depending on local contractual constraints. Registry-based follow-up using linked databases. It's going to be a mean follow-up of 2.9 years, but the trial period will really be about 5 to 6 years. 2 years that we think we're going to spend actually getting 4,800 patients into the study, and from then on, it's all follow-up. The primary outcome is all-cause mortality, and important key secondary outcomes are also included. The only post-randomization activity is intermittent adherence reporting every 6 months. Centers can participate in one of the several sub-studies where they may provide more information, such as chart review, to provide symptom data. We're also working on a study where we'll actually prospectively ask patients with different kinds of questionnaires how they feel, and that will involve consenting them into the study. But we only anticipate doing that in a small number of patients relative to the full trial. The progress to date is that the protocol has been approved by the REB, an REB in Ontario. It was approved by the Western Research Ethics Board, and that gives us approval through CTO throughout Ontario, and we're submitting to Alberta as well. The independent monitoring committee has been established, and they've met and reviewed the protocol and signed off. A dialyzer manufacturer's committed discounts on 750,000 dialyzers over the 5 years, which is enough for us to do the study. It's about $6 million worth of discounts. Grant applications have been submitted. Dialysis programs coast to coast are actually actively requesting to participate. I haven't seen that happen before, including community programs that do not typically do research. And it's certainly not because of all the money we'll be paying their sites. We're doing this on a bare bones budget. We target the first patient to be enrolled in London by May of this year, and we're working to develop symptom sub-study protocols and some additional studies to evaluate various aspects of conduct within the study. So in summary, Dialects will confidently answer an important question in dialysis. Data can bring autonomy where choices are otherwise constrained by non-clinical factors. Opt-out consent makes this study feasible and brings equity of access to research participation to patients in community hospitals. And study oversight remains a priority. So we're treating this in many ways the way we would treat drug trials as well. I want to say thank you. Lots of people are involved in this. I've listed just some of them here. Thank you.
Sorry about that. So thank you, Pavel. Now we're going to transition into our discussion. We'll begin with the questions from the panelists, and then we'll open the floor to audience questions. So panelists, if you could briefly introduce yourselves before your first question. So maybe we could start with Terry.
Good morning. My name is Terry Chanda. I'm the Regional Renal Program Director in London Health Sciences Centre and a certified nephrology nurse by background. Pavel, one of the questions I have with hospitals across the country dealing with budgetary pressures, having existing contracts in place, and as you kind of referred to that, as well as physician preference. This is such a large study. What are some of the strategies that you've used to try and recruit such a large complement of patients to the study?
Yeah, and it's a great question. And that's really the reason why we need to make this as easy as possible to enroll patients in is because we need many centers. We're looking at probably most of the dialysis programs in the country to be involved to some extent. Some will contribute more patients than others, but we need this to be easy for people to participate in and for people to enroll patients in. If it weren't for opt-out consent, we would not be able to meet these enrollment targets. We would not be able to answer this question. So that's a really key one. The second one is our industry partner providing dialyzer discounts has been attractive to centers because the discounts that they provide are actually enough that in some centers, the hospital will actually save money compared to their current dialyzer contracts. So that's helpful. Now, in centers like ours, where the contract would actually constrain how many patients we can recruit into the study, we've reached out to our physician colleagues throughout the city and our nurse practitioners to explain the situation with respect to off-contract dialyzer use, and have began to convert as many patients as possible away from off-contract dialyzers who are being used when they're being used really without a really good clinical indication, which we found was the vast majority of the time. That procedure in itself, we think actually will save programs money because when programs use off-contract dialyzers, two things can happen. One, they pay more money for off-contract dialyzers in clinical use, not in this study. But two, if they use off-contract dialyzers beyond a certain threshold of volume, they can become in breach of their contract and lose hundreds of thousands of dollars of discounts, which, that means salaries for dialysis nurses and so on. So, by actually engaging with these places and explaining to them our process for converting folks, we've learned that some of the places don't have a very robust way of monitoring dialyzer use. And as they've started to monitor, they found that they are dangerously close to breaching contracts. So they found that exercise useful. But two, they found it quite helpful to see that another center is able to convert patients back to on-contract dialyzers without any clinical consequence. So, we think that'll be helpful. So in all, I actually think that centers stand to save some money by participating in this study beyond, the benefits of, bringing research to the community.
Amy, did you want to continue with the next question?
Sure. Hi, Pavel. My name is Amy Fryer. I'm a researcher at the Manitoba Centre for Health Policy, and I'm also the Inclusion, Diversity, Equity, and Accessibility Lead for the Health Data Research Network Canada. So my question is about something you mentioned during your presentation. So you mentioned that access to research centers or academic research centers is often inequitable. I'm wondering if there are considerations that you're putting into place in terms of distribution of your study participants between rural and urban, and especially considering things like proximity to care or specialists, and how this affects the diversity of participants and the analysis of your results.
Yeah, for sure. So I think there's sort of two separate things. On one hand, we have an equity issue in that I think people should have the right and opportunity to participate in studies. They have the right, they just need the opportunity. And so there's not a lot of studies like this that are able to be accessible to community hospitals kind of in such a way. There are some community hospitals that do research. It's usually industry research that is well remunerated for those participating, either physicians or research staff, et cetera, and keeps the lights on. But studies like this, where you're studying a different kind of dialyzer, unless you make it incredibly easy, those centers just won't participate. And so I think we're making it incredibly easy. Now, that's even what I find to be very easy turns out there's certainly times when there are barriers, and so we're working on those. One thing that's really helpful is Jihad Nasrallah, who's another investigator who's working really closely on this study, is a community nephrologist. He's cross-pointed at U of T, but he's a community nephrologist in Humber, and with him, like, we're designing the strategies in a way that would work well for community physicians as well. So that's one thing, making it really easy for the community to participate. In terms of the patients themselves, the patient characteristics, there's nothing in the study that's going to limit, I think, the kinds of patients that get into the trial, other than the eligibility criteria that have been set for logistical reasons and also to increase study efficiency. We've translated and are still translating the forms, the pamphlets in many, many languages. I think it's going to end up being over 40 languages by the time that we're done. So we want to make that as accessible as possible. And even for patients who are elderly, may not cognitively be able to read the information, appreciate the information. Just like in clinical care, we've made provisions that the team can contact a substitute decision maker and tell them about the study, just as would be done in clinical care. And so that will hopefully help us get some of the more vulnerable patients into the study as well. In terms of, will the study actually include a representative sample? So representation from a statistical analysis standpoint, and whether you actually get different results in dialysis, is pertinent because our older, more frail patients have a lot of competing risks of death from things that may not be dialysis related. And when studies are enrolling younger, selected, healthier patients, they tend to minimize those competing risks and do not provide treatment effect estimates that would actually be reflective of real-world dialysis use, where many of the patients are older, they are frail, they've got tons of cardiovascular disease, and are likely to pass from one of many different causes. So by making the study such that we can include, by lowering the participation barriers, and actually enriching for those older or higher risk of mortality patients, I think we provide much more reflective treatment effect estimates. Beyond that, I don't anticipate anything about the study to limit the participation of people of different genders. This is about as simple, different genders or races. This is about as simple a study, I think, as we could possibly design.
Thank you.
Good morning, everyone, and thank you, Pavel, for the excellent presentation. My name is Corey Goldstein. I'm a CIHR postdoctoral fellow in the Methodological and Implementation Research Program at the Ottawa Hospital Research Institute, as well as the School of Epidemiology and Public Health at the University of Ottawa. I specialize in the development of ethics guidance for the design and conduct of pragmatic trials, as well as cluster randomized trials. So you can anticipate my questions are going to focus a bit on your proposed consent approach. And the first thing I want to ask is about your explanation on minimal risk. If you could just expand a bit for me. I understand that from what you said, the sort of risks of participating at sort of the population level. It seems, well, I could end up at clinic A and receive a conventional dialyzer. I can end up somewhere else and receive an expanded dialyzer. And the risks seem to be fairly comparable between the two. But for an individual patient, let's imagine that the study is not going on and I'm going to receive just conventional dialyzer as part of my treatment. And now, as a result of this study, I happen to be randomized to receive the expanded dialysis, the high filter. So what are the known or foreseeable risks for that patient that gets randomized to the intervention? And how does that differ from patients who get the conventional dialyzer? Could you just elaborate a bit for me?
Great question. Obviously not every intervention, the vast majority of interventions are really not appropriate for a study like this. Interventions where we're looking at a new molecule, a new drug, never do this way. In this case, Health Canada has approved these dialyzers without any qualification around additional risk. So there's not really, because we've never done studies that are large and follow people for a long time, the data that are available are short-term data. They focus on any changes on, blood chemistries and proteins and so on. And those studies have not shown anything indicative of harm. There's a few signals that suggest benefit. I think those signals are weak. I don't think they're convincing. But we're not anticipating anything that in the way of harm for a patient who's already receiving conventional hemodialysis.
Even with, for instance, the primary outcome being all-cause mortality. So It seems like you are looking for whether there are less cases of death for patients who receive the intervention, but equally there could be more cases, which is why you have a DSMB reviewing mortality data as the trial's ongoing. But could you just help spell that out for me?
So certainly I do not think that there's an equivalent chance of there being more death. I think that's not an accurate characterization. If we thought that that was the case, if we truly put a Bayesian prior right on the null and said, hey, there's much of a chance of people dying more as a result of this as there is from this actually reducing mortality, we would not do this study, not in the way that we're doing it now. Overwhelmingly, the chances are that there's going to be benefit. There's also an excellent chance that it just makes no difference whatsoever. If we can get that out of the way, then we can stop companies from trying to sell us products that don't make any difference and, spend millions of dollars on those. The DSMB is there because although we are doing opt-out consent, that doesn't mean we should stop monitoring the study. We don't think there's going to be any effects on mortality, but we should have still things in place that assure patients that we are paying attention. Risk is low, but we're still paying attention. It would not be better to say, we think the risk is so low, we won't even look. We've made an effort in this study to pay attention to that because we get those data from the adherence data, because one reason for non-adherence is going to be the patient's passed away. And so we have those data, why not look at them? The focus of the DSMB is predominantly, however, on data integrity, making sure that the adherence rates stay high, and making sure that people are actually completing, all the adherence checks as specified. So the concern around mortality of excess mortality is vanishingly small. I wouldn't say that just because we have a DSMB looking at that variable, we should mistake in that and think, this group's really worried about mortality.
Did the other panelists had other questions?
Pavel, just a question on the quantifying the quality of life in this study.
Yep.
Referred to the ESAS renal, but not all clinics or programs are using that. So you talked about a chart. If you can kind of expand on some other methodology that you're looking at to use some subjective patient data.
For sure. So these pragmatic trials are interesting. You know, when you're powering to mortality, you need a huge study. Many of the other outcomes don't require the same kinds of sample size. And so even if just some centers report with high fidelity, report an outcome, and you just get the outcome from those centers, if you have enough of them, you can still have adequate power on those outcomes. And so we're abstracting ESAS, our renal. These things are in flux. You know, there are sites that were doing ESAS R renal and then suddenly are not because it costs money to do, or they find that it takes too much time. The nurses don't want it. Sometimes the patients don't want to fill out the questionnaires and so on. So they are in flux, and how good data collection is going to be around ESAS R renal, we don't yet know. So for that reason, it's a tertiary outcome. However, we do want to know how patients feel on dialysis. So for that reason, we're designing a separate sub-study of this, which will actually prospectively consent patients at the time of randomization, if they want to be in that sub-study, where they're going to fill out questionnaires every few months. One of two ways: either will be on paper, or they'll get them, on their phone to complete, so that we can actually, with several other instruments, a system called Promise, that is an electronic system where you have these really, really good, really highly validated instruments for measuring how people feel on dialysis and in other settings. We're actually going to get reliable data longitudinally for a subset of those patients. Currently, that sample size looks like it's going to be about 700. That's what we're planning for. So 700 of just of that 4,800. Now, these patients are going to be more selected patients, because when you start doing prospective informed consent like this, where people are going to be filling out questionnaires, the reality is the people that are willing to do it are going to be the younger, more highly functional folks. So for that reason, we still want to collect the ESAS renal data in the centers that do report it, so that we can compare and see how representative are the effects that we're seeing from our prospective data collection compared to that chart review.
So I have another question. I don't want to say that this is a trick question, but it's one of these questions where I'm not sure if there's a great answer here. But as we know, a kind of accounting for cultural differences in care, and especially perceived cultural safety by patients, is difficult within administrative data, especially. However, these are factors that may result in variations in uptake, adherence, or outcomes across regions. And I'm, saying this from my living in Manitoba, where we have the highest Indigenous population in Canada. And I'm especially thinking about that population who we know have higher rates of kidney disease, higher disease complexity, and histories of racism within healthcare systems. So I'm wondering if there are ways that you are thinking of factoring either cultural safety or systemic racism within healthcare into your analysis or interpretation of results.
The reality is some of these factors are very difficult to measure. And so what we will present is data by region. But what we expect is the main focus of this study, and really all RCTs, ought to be to get a reliable estimate of treatment effect. And so it's the between group difference. Issues that might affect how well patients adhere to therapy, how well the providers adhere to therapy, et cetera, we expect to be distributed randomly across the two groups. So they'll be equal. And when you do a massive study like this, you expect that to be more true than if you did a small study. So for that reason, we don't think it will affect the treatment effect estimates. Having said that, we will report data by region. And so that will give us some idea, in some areas where that may be more true than others. But it's too difficult, I think, to get into those nuances, to accurately measure those things and express them. I think you risk in analysis to misrepresent more than you do to actually inform. As far as study conduct goes, we haven't built in anything additional. We're trying to keep the study as simple and as applicable to a large group of patients as possible. given limited budgets.
Just a follow up from me, could you explain sort of the reasoning behind getting the opt-out versus opt-in approach? So why is it that you can't give the same notification letter and just have patients sign that and return it, given ample time to discuss with their family, caregivers, loved ones, friends, just to make sure they understand what they're agreeing to, as opposed to relying on, we hope they read it, and if they do not want to participate, call or message. I do like that there's multiple ways that they can opt out, just sort of the reasoning behind that decision for opt out.
For sure. And so this was something, in consultation with both our, ethics committee folks, as well as with the patients on our team. A few different things came up, some of which I didn't really anticipate. So, the things that we start from a place of saying low risk study. So this sort of thing could be permissible. Of course, it's a high risk study, like your tolerance for opt out becomes lower. But low risk study, minimally invasive stuff, things that happen in routine care that nobody really gets to choose, they just are there by default. Opt out would be reasonable. Now, why can't we make it opt in? And of course, once we designed the form, that became very obvious. Why can't they just sign their name and submit that? When we talked to patients, a few things came up. First, it's very obvious that there's inertia in all of our lives. And most likely, like when people are given, especially dialysis patients, when people are given something that they, really disagree with, or it worries them, or they've reservations, etc., they're likely to go and say, I don't want this thing, if they're given lots of opportunities to do so. No problem. But if they're given something where they sort of feel like, okay, this is one of so many things that happens here and happens to me and so on, they're not likely to go, which we learned from patients, is that they're not likely to go out of their way and say, hey, I want to participate in the study. They're simply likely to say, this goes in the trash bin along with all the other junk mail I get. And so given that we need a study that enrolls, as Terry pointed out early, enrolls a huge number of patients, going to be across lots of centers, we can't afford to have 90% of patients ignore this thing, or 80% of patients ignore this thing. It really needs to go in the other direction. And we're confident that we are going to be looking at 90% of patients not opting out. So part of it was that they felt like this is just unnecessary bother, that we're a necessary, essentially, burden that we're going to be imposing on people, that the return rates are going to be very low in the dialysis units, people actually agreeing to be part of the study, not because they have some sort of opposition to it, but just because they don't want another thing to have to agree to actively. But it was very clear that everybody thinks the opt-out rates are going to be very, very low. Now, we are going to be monitoring opt-out rates. And so if we're seeing those opt-out rates are, pretty high, we'll be investigating if they're different across different centers. We'll be investigating, with audits at those centers, are the practices of making sure that patients have had adequate opportunity to opt out? Are they functioning the way we think they should be functioning? But that's really what it comes down to. Once you begin from the place of this is low risk enough that it is acceptable to opt out, everybody asks, well, then why force us to have to opt in when you know that the inertia is going to be to just do nothing?
Any other questions from the panelists? Amy, you're muted.
Of course. I have a question about EDI and research practice. You mentioned translating materials, and that's one excellent way of including EDI in research practice. And you've talked about other things in terms of research design. I'm wondering if you've considered other ways of further embedding EDI into the research practice, whether in terms of distribution of results, and I know that's a while away, or other components in terms of maybe cultural safety training for the coordinating team or factors like that?
Right. So the coordinating team does do, that's a good point. So the coordinating team does do cultural safety training. The group is the same group that's coordinated a bunch of other studies in dialysis. And it's interesting, these are studies that, like in some places, some dialysis units are on reserves. And so they've really gained some experience working with Indigenous groups. We haven't yet developed a strategy for specifically working with Indigenous groups because we're trying to get the study off the ground. But it is on our radar because this is going to be a big thing. It's going to include a lot of folks. And it's not just Indigenous groups, obviously, it's everyone else, but cultural safety training has been part of it.
Pavel, I'm wondering if you perceive of any potential challenges with monitoring prescription compliance with the dialyzer use.
Yeah, it's like all studies, what happens on the ground can differ quite a lot from center to center. So the place we begin from is first, why do we want to make sure that people are adherent? We do not think that there is going to be harm from inadherence. So that's very important because if adherence rates are slipping, all that is going to do is decrease our ability to detect signal, which is something we compensate for by having as large a study as possible and following people for a long time. So that's one important place to begin from, so that if we do have some misclassification on adherence, we say someone is adherent, but it turns out that they're not actually getting the correct dialyzer, it's not a matter of safety. Okay. Now, how do we monitor from place to place? Depending on what the electronic medical records are like at different institutions, it is possible either to get printouts of the dialysis prescriptions. It is possible to get in our institution, of course, we've worked with our data team to get the dialyzer that's on the prescription together in a list of all the patients that are in the study. So that's very helpful. Recognizing that there's going to be situations in which the dialyzer that's being used by the nurse at the bedside occasionally differs from what's actually being prescribed. Now, when one has to really do this at their own center, but in talking to the charge nurse, the nurse at our center, it's clear that these differences in the dialyzer that they actually use compared to the prescribed dialyzer are actually not very common. They tend to be they're common sort of overall. Yes, it's something that happens, but it is a one-off sort of thing that has to do often with, the last patient, we prepared this one dialyzer, they didn't show up for treatment. Can we use it for the patient that's coming in right now? Saves a dialyzer. And so those things are going to occur. We've accounted for some degree of non-adherence, around 10% in the sample size calculations. And beyond that, we want to make sure to reinforce adherence through these frequent checks. Now, the biggest form of the biggest source of inadherence we think is going to be when a patient's admitted to the hospital. There's been a change in their dialysis prescription by the inpatient team, and that change then carries out to their outpatient life when they're discharged from the hospital. And that might be a change away from the study dialyzer if the inpatient team isn't familiar with that. So to do that, every 6 months, the team reviews what the dialysis prescription is. And if there has been a change to dialysis prescription, notification goes to those investigators to say, is this something that is intentional? Is this something that can be reverted back? If you don't see a reason for it having occurred, can you revert it back? And so that's how we want to mitigate that going forward. The plan is right now to do that every 6 months, probably with a little bit more frequent at the beginning in the first 3 or 4 months of a center initiating, just to make sure that they are sticking to the script. But we'll have to see as we get going.
Final question from me. In the protocol that you shared, the exclusion criteria mentioned that people can be excluded if a healthcare provider has an overriding clinical preference for expanded hemodialysis. Could you explain when that might occur and how many prospective participants you anticipate being excluded as a result of that?
Yeah, that's a great one. So it's not common, but as with everything, these companies market aggressively, and there are, low quality data that might suggest benefit of something. And so we found even in studies of dialysate magnesium concentration in that trial that's going on, there are people that felt like, when I put my patient on a high magnesium bath, like, they go from bedridden to dancing, like it's a huge impact. And now I have many doubts that that is true, but humans are sort of pattern recognition machines, and we see patterns where they don't necessarily exist. And so there's going to be there's going to be physicians who feel, here's a complicated patient. They've got these leg cramps. I put them on this kind of dialyzer. The leg cramps went away. They were so horrible. I never want to go back and try something else. That's going to happen. Sometimes, maybe that is true. That's going to be a very small portion of patients. When you look at our center, where we actually have one of the main researchers really in expanded hemodialysis, who recruits a lot of patients into smaller studies, but at our center, even here, it's a very small minority of patients that are on those dialyzers. So I do not see more than 5% of patients, probably less than that, probably no more than 2% of patients being excluded for that reason throughout the country.
The panelists have more questions? If not, let's take some questions from our audience now. So if you have a question, please use the chat function or raise your hand and come off mute. While waiting for a question, I had myself a question, if I may. I was wondering, in the sample size calculation, it was based on a mean follow-up of 2-point-something years. I was wondering, when you apply for a grant with a project like this, how much time do you put in terms of the study duration, how long you're going to follow up? Like you'll have access to the admin data for as long as you want, but when is the primary analysis going to be done, and how do you decide when you're going to do your interim analysis?
Right. Great. So the follow-up duration is based on the anticipated number of events. And so we here have assumed that it's going to be about 17% of patients will experience the primary outcome per year. And so actually I can show you that on a separate slide. So this is we expect over 2,000 deaths actually to occur in this study to give us 90% power to detect a relative hazard reduction of just 15% in mortality. So the 2.9 years takes into account how quickly we can recruit people. So we think that over 2 years, assuming it's never exactly like that, but assuming linear recruitment over 2 years, that we'd be fully recruited at the end of 2 years from the recruitment of the first patient. From then on, folks are followed, and there's an exponential decay based on mortality that's taken into account in the total trial duration from recruitment of first patient to end of follow-up, i.e. when we actually lock the database or their administrative data. So, that's saying essentially at this point, we analyze the outcomes when people are they no longer need to stay on study dialyzers. That's going to be a grand duration of 5 years. So from first patient to the time of analysis, 5 years. There's a lag with administrative databases. So we're allowing for several months, potentially even a year post all of the administrative data being in place to be able to do that analysis. The interim is based on anticipated 50% person time. So that we will do, once we know how many patients, we will know how many patients we're following. And so we'll be able to calculate roughly what we anticipate to be the 50% person time. And it's always approximate. And we do a single interim at that time. So for for grant, like with anything for grant panels, it's sort of like we think this is going to be the duration. This is how much money we need. Ultimately, we may, based on an interim or even looking at event rates, we may get to a point where we say we need to extend for a year, depending on how many patients we've recruited and so on. So those plans may ultimately change based on event rates, but that's what we anticipate now. It does really depend on us recruiting a large number of patients very fast. Very few studies recruit that number of patients in such a short time in a single country. I think we can do it because of opt-out consent. It would be absolutely impossible without opt-out consent. In fact, before we had approval for opt-out consent, we were looking at other countries. So we were planning on, going to Brazil, Australia, and other countries as well to set up operations there. But we would much rather be able to do this entire study within Canada.
There's a question from Gordon.
Am I right in thinking or remembering that you don't have funding at the moment?
We have some money. We have, my kind of leftover money from other studies and some money from the money that we use really to develop the protocol. But we don't have money for the full study at the moment. So we're applying to CHR.
And if you don't get it, does that mean that the study will probably not progress, or will you continue it in then some sort of reduced form?
Well, so the nice thing is that the costs per patient recruited tend to be fairly low in the upfront costs of actually recruiting patients, because that expenditure is the amount of time spent on getting a patient into the study is a lot lower than you would with other methods. The payout happens over a long period of time. So as long as we can get patients in, our initial spend to do that is not going to be very large at all. A lot of costs come in later on through analysis of the administrative databases. The dialyzers are provided at a discount, and the program simply purchased them, so there's no cost there. And then some costs on the adherence. Obviously, we're optimistic that we will be funded. It's always a challenge, but we tend to start studies before full funding is secured, partially because when we did apply to CHR, and the feedback that we got is you guys haven't recruited anybody yet. So we're not sure, that this idea you've got about this rapid recruitment is true. So in truth, we hope that when we demonstrate fast recruitment, that will, deal with those reviewer comments, because it is a novel, or uncommon, I should say, assumption that we're going to be able to recruit this many patients with opt-out consent. But if we demonstrate that to people, I think they're way more likely to get the money.
I wish you luck. I forgot to start with a compliment, which was that I really enjoyed hearing about the design of the study. I think the work that you've put into it is obvious, and I wish you success with it all.
Thank you.
The question from Ahmed.
Hi, Pavel. Great presentation and great questions from the committee panelist. My question is around with any dialysis trial, you're going, especially when you have recruiting a large population, you're going to have a proportion of patients that spend time at different dialysis centers. Some of those dialysis centers might be included in your studies, others might not be. From previous work we've done, I think it was around 15 to 20% of the time spent during any 3-year period, 20% of the time spent outside of the dialysis unit where you started. I was wondering if you have thought how we would consider that issue. I know you've talked about adherence, and that's one form of quote unquote contamination. But the other form is patients spending time at different centers. I was wondering if you could comment on that. Thanks.
Sure. So that 20% you're talking about, I think, is largely people within the same program who are moving to satellite units. And so, our program is probably an excellent test bed for that because we tend to have more satellite units. So for people who don't know, dialysis is organized in a hub and spoke model where you have sort of central units that are the biggest units attached to the main hospital. And then there are satellite units that are closer to where people live in more rural communities, et cetera. And so in London, we have many of these satellite units, and some of them are as far as, an hour and a half away. And so patients, it is expected that patients will in fact move from unit to unit. They may be randomized at our main unit, but then go off to one of the satellites. For this reason, it's important that we get the entire program on board. And so really, as long as the program is on board and we oversee all of these dialysis units, I oversee patients in other units. And so, as long as they're within our net, sort of within our program, then we can enforce adherence. We can look through, what dialyzers are being prescribed. We monitor and change the prescriptions. They're under our care. What is far less common is for people to step out and go to different programs, because that would require, that's someone who's moving region, and so that'd be moving out of Southwestern Ontario off to Hamilton or Toronto or Niagara, or moving province. And those things will occur. We hope that we're going to have the majority of programs on board. It's easier in provinces outside of Ontario, actually. In Ontario, there are 26 separate renal programs. So the big battle is in Ontario. Alberta is 2 renal programs. They're just very large. And so getting one renal program there means, over 1,000 patients, many dialysis units. So getting them all on board in one go is going to facilitate tracking patients, even if they are moving from place to place. And of course, it's possible that they're going to end up in a unit that's not part of the study right now. And that's going to be on a case-by-case basis, reaching out to those physicians and saying, this patient is on this dialyzer. Can we continue with this dialyzer? They're part of the study. You don't have to do anything else. We're just going to have you check adherence every 6 months. And if people agree to do that for the small number of patients, that would be wonderful. And if they don't, they dialyze with whatever dialyzer is being used at that unit, and we simply still follow their outcomes on an intention to treat manner using the administrative databases nationally. So in short, I think it's actually going to be a really small percentage, because it's going to be people where this really applies is people who are moving programs and not simply moving units. Moving units is frequent, but I think we've got that handled.
Any hands up? We still have 2 minutes, so I may ask the last question. In terms of the inclusion criteria, I noted that it was a certain age group, patients who were at higher risk of mortality. And when we think of pragmatic trials and we try to be very inclusive of a wider range of patients so that it's very generalizable. So I guess that when you decided on these inclusion criteria, it was a consideration in terms of sample size, I guess.
Definitely is. So when we look at mortality rates on dialysis, they're horrible on average. But when you get to younger patients, 45 and younger, not with diabetes, those mortality rates actually plummet. They're much, much lower. They're like a couple of percent a year, which is still substantial. Cardiologists, like post myocardial infarction, those are the sorts of mortality rates you're looking at. So, it's still important, but it's much, much lower. And these are also folks that are likely to get transplanted relatively soon. And so they don't have a chance of even really benefiting from this for, the many years ahead. So, it's I would call it a pragmatic decision, in that it's fairly easy to ascertain that age and diabetes status. And also we just would be at risk of consider that we are expending dialyzers in this. There is a consumable. And so we wanted to, use as that consumable efficiently. And also we didn't want to have to, have a 7,000 patient trial when it's already going to be a challenge to keep within one country. And so that's the reason. I don't think it's going to have a meaningful impact on generalizability. I think that one concern we had initially when we were designing this was that if we were doing prospective, if we were doing consent the traditional way, full regulatory consent, asking people, here's the form, fill out, etc. We see in other dialysis trials is it tends to really skew towards younger, healthier people. And so we were at real risk of ending up with a cohort enriched with people that were not really at the same kind of risks, and we would get an answer that doesn't apply to the real dialysis patient. So that was partly born out of that. But still, even with opt-out, I think there's still going to be some reduction in representation of the folks with dementia, the folks that are institutionalized and coming to dialysis, the really high risk of mortality. So I think it balances out. So that's why we did it. It's not to say, the important thing I think to rule out is, do you think there would be harm of the intervention in younger people? No, I don't think so. Do you think that the intervention would not work in younger people? No, I don't think so. I just think we won't see the signal.
Okay, so thank you, Pavel. So we're going to wrap up our question and answer session.
Sorry, there's a question in the chat from some.
Sorry.
There's a bunch there.
So,
what are the most common errors or blind spots in pragmatic trials and how to avoid them?
That's a big one. What are the most common errors in pragmatic trials? I'll speak from what I have observed. I would say the biggest issue in pragmatic trials is leaning so hard on the idea of pragmatism that you run a sloppy trial. At which point, people are not adhering to the therapies, and you don't get an answer. We still have to, the pragmatism thing is important, but fundamentally, we have to have internal validity. People want to know, does the intervention work under real world conditions, but not under complete neglect. And so, pragmatic trials still require monitoring of adherence and a real effort to get people to stick to it. This is research. If we were to demonstrate, consider this, if we were to demonstrate benefit, people would be far more likely to enforce the use of one dialyzer over another. In the setting of research, it's a bit artificial because at that point, we have not yet demonstrated the superiority of one therapy over another. And so you're more likely to see in adherence, people just doing whatever they feel like doing unless you actually enforce it. So if you really want to monitor if you really want to replicate what real world conditions are going to be like, and you're not sure whether the therapy is actually effective, first you have to demonstrate that efficacy. And it's way more likely that real world conditions will subsequently reflect that demonstrated efficacy. So I'd say that's the biggest one.
Okay, so we're a bit out of time. We're gonna break for lunch now. There was a last question in the chat, but we could get that question to you, and it was from Corey Goldstein, so that we could continue that conversation of the chart. And so we'll return at 1 p.m. for our next presentation. The session links are available in the session tab on the left-hand menu. So enjoy your break, and we'll see you soon. Thank you, Pavel, for the great question.
Thank you. Bye.